The skeletal system. So what exactly makes up the skeletal system? It's composed of bones, cartilages, and ligaments. So cartilage is the forerunner of most bones, meaning it's like pre-bone. It is made before bones. And it's very flexible. It's thinner and softer than bone. It covers many joint surfaces of mature bone, and it's in areas where we need flexibility, such as our rib cage or our nose. It's smoother than bone, so in areas where bone might articulate with another bone or rub, a lot of those areas are covered in cartilage because it allows for a softer, articulate surface. We have ligaments, which are things that hold bones together at joints. So ligaments connect bones to bones. They allow for joint stability. And then we have tendons, which attach muscles to bones. And those are actually part of the muscular system, but they do play a huge role in the way we can move our bones. So there are many functions of the skeletal system, more than the obvious movement and framework. So first, we have support. The bones and vertebrae support our body. The jaw bones support your teeth, and then some bones support tissues. Protection, so our bones protect our internal organs, like our brain, our heart, those kind of things. Movement, so it gives us movement. Our bones provide like a framework for our body, and the way the muscles attach to them, it allows us to move, walk, pick things up, talk, all those kind of things. Bones play a huge role in that. They play a role in electrolyte balance, specifically calcium and phosphate. They play a role in acid-base balance, specifically pH changes in blood with phosphate and carbonate salts. And then they play a huge role in blood formation. As we know, the bone marrow makes our red blood cells and a large portion of our white blood cells. So without bones, we wouldn't have blood or an immune system. So bone tissue is also called osseous tissue. Osseous just means like of bone. And it's a connective tissue with the matrix hardened by calcium phosphate and other minerals. So it's a tissue that has been hardened because it has lots of calcium in it. Mineralization or calcification is just a process of bone hardening, and bone hardens after it's formed. It has to mature and become hard. So it mineralizes or calcifies after it's been created. Individual bones consist of bone tissue, bone marrow, cartilage, adipose tissue, which is also fat tissue, nervous tissue, which is your nerve cells, and then fibrous connective tissue, which are layers of the bones that actually help connect them to organs, muscles, parts of your body, stuff like that. So each bone consists of these different types of tissue. So bone is connective tissue that consists of cells, fibers, and ground substance. And it has 4 principal types of cells. So you have osteogenic cells, osteoblasts, osteocytes, and osteoclasts. Those are the 4 classifications of bone cells. So osteogenic cells are just bone stem cells. Basically, they're stem cells found in the endosteum or the inner layer of the periosteum of your bone, and they come from embryonic stem cells. They multiply continuously and give rise to other bone types of cells. So all bone cells start as an osteogenic cell, which is just a classified stem cell. Basically, it's a stem cell that has decided, okay, I'm going to be bone cell, and then it gives way to one of the other 3 types of bone cells. That's osteogenic. It's like a baby bone cell. Osteoblasts are bone-forming cells, and you can remember this because the B in blast means building. So osteoblasts are the osteobuilders. They form single layers of cells under the endosteum and the periosteum, and they grow in a circle pattern outward. They secrete osteocalcin, which stimulates insulin secretion from the pancreas. They can stimulate osteogenic cells to multiply rapidly if there is stress in the bone or if the bone has broken. So if you break a bone, your osteoblast can stimulate the osteogenic cells to multiply and turn into more osteoblasts or into osteocytes to repair or build more bone in the area. So we have osteogenic, which are the stem cells of bone cells, and then osteoblasts, the bone builders. So osteocytes, or bone cells, are former osteoblasts that became trapped in the matrix as they were building. So if you look at how this bone diagram over here is, the center is where it starts to build. So you have an osteoblast, and it starts circling and building around and around, and it goes out and out and out and out. As it builds around, these osteoblasts are going to get trapped in different little pockets of the circle in the bone. And once they become trapped, they become osteocytes or just regular bone cells, and they stay there. They can't get out. So some of them get stuck, some of them get reabsorbed. They can act as strain sensors. So when stressed, they can produce signals that regulate bone remodeling. So as stress is applied to bones, your bones can remodel, and we'll talk about that towards the end of the lecture. But they can act as bone remodelers, but usually they are just trapped osteoblasts that got stuck in the bony matrix when the bone was being built. So we talked about bone builders. Now we're going to talk about the ones that break down bones. So osteoblasts are the builders, the B's build, and then osteoclasts are the ones that destroy bone or break bone down. So these are bone dissolving cells that are found on the surface. They develop from the same bone marrow stem cells that give rise to blood cells. And they are very large cells formed from fusion of tons of these osteogenic cells. They have multiple nucleus in each, and you can see in the image there's like 5, 6 nucleus in each of those. They have a ruffled border, and they often reside in reabsorption bays or pits in the bone surface, so little indentations in the bone surface. You can see these cells more frequently. They dissolve bone for bone remodeling and also electrolyte balance. And the dissolving of bone is called osteolysis. So osteo means bone, and lysis means to break down or destroy. So osteolysis or osteolysis just means to break down or destroy bone. And the osteoclasts do this. Sometimes they do it because of pressure on the bones for bone reshaping or remodeling, but more times than not, they do it in response to hypocalcemia or low calcium in the blood. And we'll talk about that when we get to electrolyte regulation towards the end of the PowerPoint. So here's just a little graphic of how bone cells develop. So everything starts as an osteogenic cell, and then it differentiates either into an osteoblast or an osteoclast. Okay, and then an osteoblast that gets stuck in the bony matrix as it's building bones becomes an osteocyte. If you're an osteoclast, you stay an osteoclast. So it's osteogenic cell, and then either clast or blast, and then a stuck blast becomes an osteocyte. So the matrix of your bone is made up of both organic and inorganic matter. So the organic matter is anything that is made or built by the osteoblast. So this is collagen, carb protein complexes, things like that. The inorganic matter is your calcium carbonate, and other minerals like fluoride, sodium, potassium, magnesium. So the majority of your bone mass, the matrix, is inorganic matter. And then only 1/3 of it is the organic matter, or the things that are actually built by the osteoblast. The rest is all minerals and stuff that is stored in your bones. So our bone matrix is a composite material, meaning that it's made up of more than one thing. It has a ceramic and a polymer layer. The ceramic layer is the hard mineral layer, and the polymer layer is the softer protein layer. The ceramic portion allows for support of the body weight without our bones sagging. It makes our bones strong. The polymer layer makes them flexible, so they're not too strong where they snap like glass. So when you have an issue either way, so let's say your bones are too soft, your ceramic portion is lacking, you have rickets, which means that you have a mineral deficiency, and it causes soft, deformed bones. So the ceramic layer, the ceramic portion of your bony matrix is too soft, it's not strong enough. Or you have not enough polymer layer, you don't have enough flexibility. That's like osteogenesis imperfecta, which is called brittle bone disease or glass bone disease. And it's a defect in the collagen deposition, meaning that the bones are not flexible enough. They're more glass-like, and the smallest little bump or tug can cause a fracture. So the bone marrow is soft tissue that occupies the marrow cavities of the long bones and small spaces of the spongy bones. Typically, the long bones, we see the bone marrow in like the shaft area of the arms and leg bones, and then you can see it in the spongy areas of certain bones, like your ribs and your hips. Red marrow is myeloid tissue, and this is the hematopoietic tissue, meaning it produces blood cells, specifically red blood cells and white blood cells for immune system. In nearly every child, there is red marrow in all the long bones. In adults, we find it in the skull, the vertebrae, the rib, sternum, part of pelvic girdle, and the proximal heads of the humerus and femur. But in children, it's everywhere in the body, all over the place. And if you think about it, it makes sense because children are growing. They need to produce more blood. They need to produce more white blood cells because they're exposed to more bacteria and germs than adults. So they have more blood-making tissues. Once they mature and become adults, there's less because we're not growing anymore. We don't need to continuously resupply blood and add more blood for growth. So we have yellow marrow in adults, and this is found, this is your fatty marrow, and it doesn't produce blood, but it can transform back to red marrow if you are chronically anemic. So if something is wrong with your marrow, or you're not producing enough blood cells, your yellow marrow can turn back to red marrow and produce red blood cells. But it's usually like if you have yellow marrow that's producing blood and it has converted back to red marrow, you're critically ill. Like, so there's something really wrong. So in this diagram here of the skeleton, you can see that all the red is where the red marrow is, and then the white bones is where you would find the yellow marrow. And in a child, the entire body would be red. So how do bones develop? So the development of bone is called ossification or osteogenesis. And if we go back to medical terminology, genesis just means to create or make, and osteo means bone. So it's the making of bone. On humans, the fetuses and babies, the bone will develop in two methods. So there's intramembranous ossification, which produces flat bones of the skull, clavicle, part of the mandible in a fetus or an unborn baby. And then it thickens long bones throughout life. And then then there's endochondral ossification is the other type of bone formation. So endochondral ossification is like growth ossification. So it's going to show the bones growing from the growth plates outward. So if you look on these diagrams, you can see that there is an epiphyseal plate, which is also your growth plate. So it's going to be the epiphyseal center is going to form to make the growth plate area in the bone. And then the bone is always going to grow at that growth plate. Once the child is done growing, the growth plates are closed, no more growth would happen. Okay, but this is endochondral, meaning growth plate towards the end of the bone ossification. So in endochondral ossification, when you are a child or a baby, the epiphysis fills with spongy bones. The cartilage is limited to the articular cartilage that covers each joint surface and to the epiphyseal plate or the growth plate. So a thin wall of cartilage is going to separate the two cavities, and the epiphyseal plate persists all the way until adolescence or the end of puberty, and this is the growth zone for bone elongation. So bone is going to grow inside that plate, pushing the ends of the bone further apart. By the late teens or early 20s, all the remaining cartilage in the growth plate is generally consumed, and it's considered to be closed. So the epiphysis and the diaphysis gap is going to be closed. There will be no growth plate anymore. The marrow cavities will become one single cavity because there's no plate separating them, and then your bone can no longer grow. So ossification will continue throughout life with growth and remodeling of bones. So your bones will continue to grow or repair themselves and remodel, and then you can grow your bone in two different directions. So they can either grow lengthwise or widthwise. So here's a 12-week fetus, the skeleton. So you can see that there are endochondral bones, which are the long bones, that they're ossified. That you can see them, they're much more dense and solid versus the intraosseous ossification bones, like the skull bones. You can see it looks really, really spongy. They're not as hardened yet. But this is just two different formations of bones. And this is, you can see it actually in the fetus. Once you're born, it's really hard to tell which bones have developed intramembranously or endochondral. So bone growth or bone elongation. So bone elongation typically occurs in infants and children because adults don't grow. Like our bones are not getting longer, right? So they grow at the epiphyseal plate or the growth plate. It's a cartilage transition from bone. So if you look on this image here, down in the wrist, you can see where the radius meets the first wrist bone or the scaphoid. There's a plate in between. It's like a gap. That is an epiphyseal plate. That's a growth plate. The wider or the bigger that opening is, the more time that child has to grow. So it functions as the growth zone where bone elongates. It has a typical hyaline cartilage in the middle with transition zones on either side where cartilage is replaced by bone. So you have a cartilage line in the middle and bone will deposit on either side of it. The metaphysis is a zone of transition facing the marrow cavity. This is an interstitial growth from within. The bone elongation is a result of cartilage growth within the epiphyseal plate, so inside that growth plate. The epiphysis closes when the cartilage is gone, okay? And then the epiphyseal line of spongy bone marks site of former epiphyseal plate. Lengthwise growth is finished when there is no gap anymore and it's just a line. And this can occur at different ages in different bones. Some bones grow longer. So if you think of like legs are going to grow until, especially in boys, until 18, 19 probably, because they're still growing in height. Whereas bones like in your skull might be done at growing at like 14 or 15. And then also it depends on when the child hits puberty, when they stop growing, how much growth hormone they have, and how open their growth plates are. The more open the growth plate is, the more room there is for bone to be deposited in there. As it closes or gets more narrow, you can tell that they're approaching the end of their growth ages. And then they should be done growing at some point soon if it's really, really narrow and closed. So we're talking about bone growth. Let's talk about not growing bone. So dwarfism. So you can have achondroplastic dwarfism, which means that the long bones stop growing in childhood and they don't continue to grow past puberty, like most people do. They usually have a normal torso and short limbs because it only affects the long bones. So their wrist bones, their ankle bones, their ribs, their skull, all that are normal. They are normal size. It's the long bones that stop growing. So the fingers, the legs, the arms. So it's caused by a spontaneous mutation that causes a dominant allele. And then if they get one of them, they have dwarfism. And that's why it's common for dwarfs to have dwarf children, because it is a dominant trait. However, people with dwarfism can have normal heighted children. And then you have pituitary dwarfism, which is not a genetic dwarfism. It just means that you lack growth hormone. So you don't produce or you don't release, one of the two, enough growth hormone to make your body grow. It doesn't stimulate the production of new bone cells and new proteins to stimulate growth in the body. So usually these people have normal proportions. All of their limbs and their torso and their head are all very proportionate. They're just smaller than normal. So they're all proportionate. They're just little because everything was growing at the same rate. It just stopped really, really early. So they're usually like 4'5", 4'6", something like that, 4'10". They're just tiny, but they're all proportionate. Whereas people that have dwarfism usually have disproportionate limbs compared to the torso of their body. So bone widening and thickening. Your bones can widen and thicken over time. And it's called appositional growth. And it occurs at the bone surface. So not inside the bone, not at the growth plates. It's actually on the surface of the bone. So it's continual growth in diameter and thickness. It's intramembranous ossification, and osteoblasts of the inner periosteum are depositing osteoid tissue in the area. They become trapped as the tissue calcifies. They lay down matrix in layers parallel to the surface, and then osteoclasts of the endosteum enlarge the marrow cavity. So what it is you have just like a cavity, and they go around and deposit more and more and more bone on it, and it makes it thicker. They just work around in circles, and they just deposits more and more. So it just widens or thickens the bone in diameter, basically. It's not making it longer, it's making it more thicker around. And then in this process, osteoblasts are depositing bone tissue, and sometimes they trap themselves as they're depositing the bone tissue, and they get stuck in it when it calcifies, and then they become osteocytes. So I've mentioned the term bone remodeling. Let's talk about what exactly that is. So it is absorption and redepositing your bone. And this happens throughout our whole life. About 10% of our total skeleton is remodeled over time. So the remodeling can be good or it can be bad, depending on under like which circumstances you're doing bone remodeling. So if you have mini fractures in anything like that in your bone, it's gonna absorb the broken parts and then redeposit them to correct it. So it can heal your mini fractures. It can heal your injured bone, so your real fractures. It can release minerals into the blood. So if you have a really, really low calcium level or really low phosphorus level, the body knows that there is calcium and phosphorus stored in your bones. And it knows if it breaks down those bones that it can get those electrolytes released into your blood. So we do a little bit of breaking down to release minerals like calcium and phosphorus. And it can reshape bones to response to use and disuse. So as you use your bones can be remodeled into the way that it fits you over time. So for example, if you're constantly sitting with really bad posture with your neck hunched forward and putting a lot of stress on your cervical vertebrae back there, your bone will remodel into that shape over time, which would cause you to have like a hunchback. So it can remodel from stress and continuous use in the same position. So there's Wolff's Law of Bone, and it says that bones will adapt to the mechanical degree of loading, meaning however you're using the bone, especially if you're putting a lot of stress on it, the bone will adapt and become shaped like that, which is why people get hunchbacks if they walk all hunched over. Or if you walk bow-legged, your knees will eventually start reshaping. Your femurs will kind of bow out to reshape more bow-legged because that's the way they're used the most. You're putting stress on them to make them turn like that, so they will respond and reshape to be turned like that. So remodeling is a collaborative and precise action between the osteoblast and the osteoclast. So the osteoclast have to break down the bone and the osteoblasts have to rebuild it. And then the bony processes grow larger in response to mechanical stress. So if you have bony processes on your body and you're mechanically stressing them, you can get them to grow larger just because you're putting a lot of stress. And mechanical stress just means physical stress, pressure. You're pushing on it, you're tugging on it, there's a lot of excess weight on it, things like that. So the physiology of osseous tissue, what does it actually do? So mature bones remain metabolically active, like they do work. They're involved in their own maintenance and growth, and especially of remodeling. So they monitor and kind of keep track of how often they grow, if they need to be repaired and maintain themselves, and then remodeling. They exert a profound influence over the rest of the body by exchanging minerals with tissue fluid. So again, we can break down bones to release minerals, and we can build up bones to use up or store minerals. So if you have low calcium, we can break the bones down to release it from the blood. Or if you have a high calcium level, we can get rid of some of that calcium by building up or storing it in bones. So usually when you have a calcium imbalance in your skeletal system, it usually disrupts other organ systems, especially nervous and muscular. So there are systems that rely on calcium. The nerves rely on calcium to create their electrical stimulus, as well as the heart. So when we have a problem with calcium levels and we don't have that homeostasis in them, the skeleton's not maintaining that homeostasis, we can have a lot of problems in our nervous system and our muscular system, especially in the muscles of the heart. So mineral deposition and resorption is just a process in which calcium, phosphate, and other ions are taken from the blood and deposited in the bone, or the other way, taken from the bone and deposited into the blood. So osteoblasts are the builders. They produce collagen fibers that spiral the length of the osteon. They become encrusted with minerals. So any minerals that are floating around will crust all over them and kind of cake on them. And then they will harden over time. And because it's hardened, they're usually stuck in there. They can't just come back out because the bone has hardened. So if you have abnormal calcification or ectopic ossification, that means that soft tissues and organs like your lungs, your brain, your eyes, muscles, tendons, anything like that are ossifying or calcifying, hardening when they should not be. The opposite happens when we are going from bone to blood. We use the osteoclast to break it down so they can be released out of the hard bony matrix. Because again, the bones, they harden as they are formed, and any kind of minerals that are stuck in there, that were in there, are now stuck. They can't get out because it's solid. Okay, so mineral deposition means going from blood to bone. We're depositing the minerals into the bone. Okay, and they're just getting stuck in between the layers of bone. They can't get out because it's hardened. And it's usually calcium and phosphorus are the most common in the bone. So mineral resorption just means that we are breaking down bones to reabsorb those minerals back into the bloodstream. So these are performed by the osteoclasts. So the osteoclasts are the breakdown cells of bones. And then there's hydrogen pumps in the membranes that secrete hydrogen into the space between the osteoclast and the bone surface. Chloride ions follow by electrical attraction, and then it makes the pH much higher or more acidic, And then this dissolves bone materials. As it dissolves the materials, it's no longer hardened, and all those minerals that were stored in there can now be released into the blood. So this is like it happens in all of our bones. But to get like an idea of where you can see it like in real life, if it's not like a problem for somebody, we use this for moving teeth with braces. So we just wait for the force of the braces to cause resorption of these minerals, which softens the area around the teeth in the front where the pressure is being applied, and it lets it move. We resorb some of those minerals, and then the osteoblast will go back and rebuild on the other side where there is like less compression and there's more space. So looking at this image, you can see here's a tooth, and it's being pulled to the left, right? Where these little purple guys are, that's the osteoclast side. That's where the tooth is pushing against the next tooth or the gum, right? We're trying to pull it that way. So we can have the osteoclast break down a little bit here, release some of the minerals, and then the osteoblast will redeposit it on the back side of the tooth. And it'll just it'll cause it to reform in the proper space. And this is how we move teeth. This is why it takes time, because we're not just actually yanking the teeth around and pushing them around. We're actually allowing the cells to reabsorb the minerals from the bones and then redeposit them on the back side. So let's talk a little bit about calcium homeostasis and how our body maintains our calcium levels. So calcium and phosphate are used for much more than bone. We use them for nerves, we use them for muscles, we use them for our heart, and they're just stored in bone, and then they're taken out when we need them. So if you're providing your body with adequate calcium and vitamin D, we're probably not going to take much of it out of our bones. But if you're limiting your body and not providing it with the calcium, vitamin D, phosphate, things like that it needs, it will pull them from the bones. So about 18% of your skeletal calcium is exchanged each year with your blood, and that's normal. Anything more than that, you probably have some kind of limiting factors that are keeping you from getting enough calcium, or something is wrong. And then any less than that, you're probably giving yourself too much. Normal calcium concentration in your blood should be 9.2 to 10.4. So when you get your labs done, it should be in that area. If you have too little, then you're probably going to be breaking down your bones more frequently. If you have too much, then you're probably going to be building up your bones or hardening of your bones. You can overdo it, but it's better to have more than less. So hypocalcemia just means you don't have enough, right? Hypo is low, calcemia, calcium. So you don't have enough calcium in your blood. So this can change the membrane potentials and cause overly excitable nervous system and or tetany, which is muscle spasms. So too little of this ion can cause your muscles to twitch and spasm. It can cause palpitations in your heart because your heart really relies on calcium to start its electrical conductivity. If you have a laryngospasm, it can cause suffocation, which is a spasm in the throat. So typically, hypocalcemia is caused by vitamin D deficiency, diarrhea, thyroid tumors, or underactive parathyroid glands. So the easy one is diarrhea. You're just getting rid of electrolytes because you have diarrhea, right? You don't have time to absorb it. It's coming out too fast. Thyroid tumors usually mess up the thyroid, and they're not secreting enough or too much thyroid hormone. And this is going to cause issues with your parathyroid as well. If your parathyroid is not releasing enough parathyroid hormone to break down bone to keep calcium levels high, you're going to have low calcium. And then vitamin D deficiency. You have to have vitamin D to absorb calcium. You can take calcium all day long, 100 pills a day, and if you don't have vitamin D from the sun, or if you're not taking a supplement, you're not going to absorb it. Usually a calcium, like vitamin, it's calcium and vitamin D together because you need them both. So make sure if you're taking a calcium supplement, you're taking vitamin D because they go together. You have to have both. So pregnancy and lactation can increase the risk of hypocalcemia because the baby is going to take the calcium. If there's not enough for mom to give to the baby and mom goes without, baby gets. Same thing with breastfeeding. There's going to be calcium in that breast milk, and there's going to be enough to supply the baby. Mom's going to go without. So hypercalcemia means you have too much calcium. So this makes everything less responsive, and it messes up the stimulation because the ions are all out of whack. It can cause emotional disturbances, muscle weakness, and cardiac arrest. Hypercalcemia is really, really rare because it's easier to regulate the excess. we can build more bone or we can excrete it in the kidneys, in your urine. So it's way uncommon. Hypocalcemia is very common because if we're not giving our bodies enough, we can't just make extra. If we have extra, we can get rid of it. So the homeostasis of calcium depends on multiple things. It's not just what you're eating. It relies on your dietary intake, your urinary and fecal losses, and exchanges between osseous tissue and blood. So you have 3 hormones that do this. You have calcitriol, calcitonin, and parathyroid or PTH hormone. They all work together and against each other in different ways to balance everything out. So calcitriol is an active form of vitamin D, and it's produced in the liver, skin, and kidneys. It is actually produced when you have exposure to UV radiation. So if you want to increase your vitamin D, go out in the sunlight. It's going to get these cells to convert into calcitriol. Calcitriol is something that increases calcium. So sunlight will increase calcitriol, increase calcium levels in your body. So what is calcitriol? It's a hormone that raises your blood calcium level. So mainly it increases calcium absorption by the small intestine. So any calcium that you take in, it's going to increase the small intestine's absorption of that. So it's going to particularly look for that calcium and absorb it so we can keep it. It also increases calcium reabsorption from the skeleton, meaning that it stimulates the osteoblast to release RANKL, which is chemicals that stimulate production of more osteoclasts. So we're going to make more osteoclasts because remember, those are the ones that break down the bones. So they're going to break down the bone, which would release calcium. It weakly promotes kidney reabsorption of calcium, so less is lost in the urine. So it has a little effect on the kidney and says, hey, if you get any calcium coming through, don't throw it out as waste in the urine, reabsorb it and keep it in the blood. We're already low. So calcitriol increases calcium by increasing osteoclast activity and by causing the kidneys to reabsorb calcium. Okay? It also reabsorbs in the small intestine. Calcitriol is stimulated by sun exposure. It's a form of vitamin D. Here's just like a little graphic of calcitriol synthesis, saying that you have these cells that are converted when they are exposed to the UV light. So when you're out in the sunlight, and then it causes it to be released by the liver. It has an effect on the kidneys. It also has an effect on bones. So the osteoclasts can start breaking down the bones. The small intestine can start absorbing the calcium, and then the kidneys can hang on to the calcium and not excrete it in the urine. So calcitriol is necessary for bone deposition or depositing of bones. It helps provide adequate calcium and phosphate. So when you have inadequate calcitriol, it can cause abnormal softness of bones in children, which is called rickets. And then it's the same thing in adults, but it's called osteomalacia. And mal just means bad, so it's like bad bone disease. Rickets in children, it just means the bones are really, really soft. Usually it looks like bow-leggedness because the bones, they're soft, so they can kind of just like form outward instead of being strong and stiff. They kind of like mold over. And it just means that you don't have enough calcium and phosphate to make your bones hard and strong. They're really, really soft. So calcitonin is secreted by your C cells, which are in your thyroid gland when your blood calcium levels rise too high. So calcitonin, if you just need to remember this, it tones it down. So you need calcitonin. When you have too much, we can tone it down. So too much calcium, you're going to release calcitonin. It lowers blood calcium concentration in 2 ways. So it can inhibit osteoclasts. That way we're not breaking down bones to release more calcium because we don't need it. And then it stimulates osteoblasts to build more bone up. So we need to take the calcium we have and put it in bone and store it to get it out of the blood and not break down anymore to release it. So this is really important in children. It has a weak effect in adults. Osteoclasts are more active in children due to faster remodeling because children are growing and then they get hurt. Their bones are constantly changing. You can mold bones a lot easier in children because of this. And this may inhibit bone loss in pregnant and lactating women. And just remember, tone it down. So if you have higher levels of calcitonin, it's going to keep the calcium levels down, which means you put more into the bones, make the bones stronger and harder. So parathyroid hormone, we talked about this a little bit. Okay, but let's go into details now. So it's secreted by the parathyroid glands, which are on the sides of your thyroid. It's released when calcium levels are low in blood. So you release parathyroid and it makes you break down bone to release the calcium into the blood, right? If we break down the bone, we get more calcium in the blood. It raises the calcium levels in 4 ways. So it stimulates the osteoblast to secrete RA and KL, thereby increasing osteoclast population and bone reabsorption. So it makes more osteoclasts. More osteoclasts means more breaking down bone. It promotes calcium reabsorption by the kidneys. Okay, so instead of peeing out the calcium, our kidneys are reabsorbing it or keeping it in the body. It promotes the final step of calcitriol synthesis in the kidneys, which enhances calcium raising effect of calcitriol. And it inhibits collagen synthesis by osteoblasts, inhibiting bone deposition. So it makes osteoclasts break down bone to release. It makes osteoblasts not build up to store. It makes the kidneys keep calcium instead of making you pee it out. And then it produces calcitriol, or it pushes calcitriol synthesis to make more calcitriol, which makes us raise calcium as well. So it doesn't just build and break down, it has effects on the kidneys as well. Here's just a diagram of calcium homeostasis, and it just shows you if your calcium levels get too high, what happens, and too low, what happens. And just remember that when the calcium levels are out of whack, it either causes us to make more bone, or harden our bones, or weaken our bones and break them down. And it also has an effect on kidneys. So in addition to calcium homeostasis, our bones play a huge role in phosphate homeostasis. So the average adult has 500 to 800 grams of phosphorus, with 85 to 90% of it being stored in your bones. So pretty much all of your phosphorus is in your bones. Usually you have a normal count of 3.5 to 4 in your blood. So when we get your labs done, 3.5 to 4 is normal for phosphorus. Phosphate is also needed for DNA, RNA, ATP, and phospholipid production. If you don't have this, you cannot make DNA, you cannot make RNA, you cannot make ATP. So if you're not making DNA, you're not able to do mitosis and make new cells. So are you able to make new blood cells? Are you able to make new bone cells? Probably not, because we can't make DNA. If you can't make RNA, you can't do protein synthesis. So you're not making any new proteins. So you're probably not healing. If you can't make ATP, you're probably going to be exhausted, right? Because you're not making energy. So these are really important in all of these things. Phosphate levels are not regulated as tightly as calcium levels. So the body doesn't check them like as much. It doesn't really care as much. So there's a little bit more wiggle room for phosphorus. Calcitriol raises phosphate levels by promoting its absorption in the small intestines. So as well as increasing calcium, it has a role in reabsorption in the small intestine by making phosphates be reabsorbed in the intestines as well. So it can also raise that. And PTH lowers blood phosphate levels by promoting its urinary excretion. So when parathyroid hormone is released and it causes the reuptake of calcium in the kidneys, it actually causes excreting of phosphorus from the kidneys. So that has an effect both ways, one on calcium and one on phosphorus, but in opposite mechanisms. Like they go the opposite direction. One is absorbed more and one is peed out more. So there's other things that affect bones besides calcium and growth hormone and stuff like that. So we have 20 other hormones, vitamins, and growth factors that affect the bones. Bone growth, especially in puberty, is really, really rapid. The surges of growth hormone, estrogen, and testosterone can occur and promote ossification. These hormones are going to stimulate multiplication of those osteogenic cells, or those bone stem cells. It's going to make the matrix deposition of osteoblast occur much, much faster. And then it's going to cause the metaphysis and stuff like that to get bigger in your bones. So it can cause rapid bone growth when you have surges of these hormones. Specifically growth hormone, that's the one that's going to make it surge as basically the most, because its job is to make you grow. So if you're secreting growth hormone, of course your bones are going to grow because everything's growing. So girls typically grow faster than boys and reach full height earlier, which is pretty common that we know that, right? So typically by time a girl has started menstruation, she's done growing. Estrogen has a stronger effect than testosterone in bone growth. So when a girl starts puberty, she releases a lot of estrogen and makes them grow quicker, but then it stops. Males grow for a longer time and they also grow taller because they have way less estrogen. It takes more time. Anabolic steroids can cause growth to stop. So if you were taking anabolic steroids, it can cause your growth plates to prematurely close, meaning that you cannot grow anymore because if you have no growth plate, your bone doesn't grow. That's where it grows from. So this can cause abnormally short adult stature. So taking anabolic steroids in your teen years is not a good idea unless you want to be really short because it's gonna cut you off on your growth for sure. So let's talk about some bone disorders. So orthopedics is the branch of medicine that deals with the prevention and correction of injuries of bones, tendons, ligaments, things like that, and most muscles also. Usually it's like a sports injury clinic, something like that. The name implies its origin as a field treating skeletal deformities in children. So it was bone, and then pedics came from taking care of children. So it used to be like a children's bone doctor, and then it kind of became an everybody bone doctor. It includes the design of artificial joints and limbs and the treatment of athletic injuries. So joint sprains, knees, ankles, shoulders, things like that, torn ligaments, hip replacements, prosthetics of the limbs. Orthopedics do all of that. It's like pretty much anything with your arms and legs, an orthopedic is going to deal with you. And then any other bones in your body injury, orthopedic doctor is going to deal with it. So first, let's talk about fractures because this is probably the most common thing that can happen to bones, right? So you can break a bone. So there's different types of fractures. Stress fractures is a break caused by abnormal trauma to a bone. So you fell, you put stress on the bone, it snapped. You got hit by a car, you put stress on the bone and it broke, right? That's a stress fracture. Pathological fracture just means a bone that is broken because it's weakened by a disease. You don't really have to get hurt or get hit, anything like that. It just means your bone cracked because it was weak or sick. And this can happen by bone cancer or osteoporosis. So usually the bones are broken by something that would have not broken a healthy bone. So let's say you hit your elbow on your desk. It broke your arm. It should not be breaking your arm just by hitting your elbow on your desk. But in somebody with bone cancer, the bone could be very weak and it could cause that. So that would be a pathological fracture. So fractures are classified by structural characteristics. So the direction of the fracture, if it breaks the skin, if it's in multiple pieces. So for example, you can have a green stick or a hairline fracture, and that just tells you how it's split. You can have a buckle, meaning that it split and then like slid, and then they kind of went back next to each other. You can have displaced, meaning that it has completely moved or it's buckled, like in this B. Non-displaced means it's just a fracture or a crack in the bone, and it's still in its normal place. Typically, non-displaced would be something that you would splint or cast. Displaced, that this picture, they're probably going to need surgery because looks like the tib and the fib are both broken together. So the person is going to be completely non-weight bearing on this leg. Comminuted means there's 3 or more pieces broken. So it's more like a shatter. And if you look at the C, you can see there's multiple areas that are broken. And then a green stick is when it kind of snaps outward. And then you can have a compound fracture, which is where the bone is broken and then the bones go through the skin. So you broke your arm and the bone came out of your skin. That's a compound fracture. So now you have broken bone as well as a wound in the skin. So the steps of which a bone is going to heal itself. First, you're going to have a hematomal formation, which just means a whole bunch of blood rushes to the area. It's going to cause that swelling and bruising that you always see after a fracture. Then you're going to have a soft callus formation. This just means that collagen and cartilage are going to be in the area, and it's going to start converting the tissue in that area to the soft callus. Okay, and then it's going to start becoming a hard callus. So osteoblasts are going to start depositing bony tissue around the fracture site, and they're going to keep depositing it until both broken pieces basically are connected back together. And then there's bone remodeling. So small bone fragments are going to be removed by the osteoclast, while the osteoblasts keep building spongy bone and then turn it into hard bone. So fractures are either treated with open or closed reduction. Closed means we treated it without opening up the body, basically. It's closed. So we put a cast on or a splint or something like that, and we didn't have to do any surgery. There was nothing open, right? We kept it all closed. So cast is the most common thing. We can set bones, cast them, splint them. Open reduction means you had to have surgery. Typically, it involves some kind of internal fixation, which just means that they had to put screws and plates in. So ORIF means open reduction internal fixation, meaning they had to open you up to reduce the bone or fix it. And then they applied internal fixators like screws, plates, hardware to set the bone in place and hold it so it could heal. So that would be like surgery. If you broke your bone in half, your leg, and you had to have surgery, Now you have rods in your leg. You have an internal fixator or an internal fixation device that is holding your bone in place. Sometimes they stay in forever. Sometimes they come out 6 months after. Sometimes they come out 5 years after. It just depends on the type of surgery, the type of fracture, what the doctor thinks is best. And we can also treat fractures with traction. So traction is really common in the legs, specifically the femur or the thigh bone. It's really common, especially in children, because they're still growing. So fractures of the femur in children are usually treated with traction because we need to align the bone and we need to relieve the force of the thigh muscle to allow the bone to still grow. So usually hip fractures in older adults are pinned, and they're usually encouraged to walk within hours of surgery. So usually if you have a hip fracture and you have surgery, you're on your feet 2 hours after you wake up. They want you moving. If it takes more than 2 months to heal, they can do electrical stimulation or suppress effects of parathyroid hormone to try to keep the bone softer. It just depends on what's happening. But so traction, if you look at this image, they have these screws in the tibia here, in the shin bone, and it's pulling on it. This relieves the force of the thigh muscle on the femur because the thigh muscle is tight and it kind of squishes. We don't want that squishing. We want the femur to be free and open so it has room to grow and repair at the same time. So it's really common in children that they use some kind of traction, like Buck's traction is really common, and it's like this. It's a weight that pulls on that. And yes, they have screws sticking out of their leg with devices attached to them. This is also common in neck injuries. If a child usually breaks their neck or some of the cervical vertebrae, they usually end up in a halo because it keeps the head the right way to allow to reduce some of the tension on those bones so they can heal properly. So other bone disorders. So osteoporosis is one of the most common bone disorders, or it is the most common bone disorder. And it's just a severe loss of bone density. It's really common in postmenopausal women, especially white women. And it's just because estrogen levels deplete so much after menopause, and they're really important in calcium absorption. So the bone lose mass and become really, really brittle due to the loss of organic matrix and the minerals like calcium. This affects spongy bone the most since it is the most metabolically active or the ones that use the most minerals. It makes people subject to pathological fractures, meaning fractures that just form for no reason. You don't have to fall and get hurt, but you can get a stress fracture and it's just because you turned or put too much weight on a bone and it fractured because it was so brittle. This can cause things like kyphosis, which is a widow's hump, which is a deformity of the spine due to vertebral bone loss, so softening of the bones in the vertebrae. And then complications of loss of mobility are pneumonia and thrombosis. So as people become more immobile because their bones are weakening, they get more at risk for things like pneumonia and thrombosis or blood clots. So pneumonia, because you're not breathing, you're not exercising your lungs, you're not doing breathing exercises, you're not up and moving, fluid can accumulate. And then thrombosis is clotting. When you don't get up and move, it's really hard for your body to return blood back to the heart. And it can cause blood to sit in those areas like your legs and clot. So it puts you at more risk for blood clots if you're not as active. And osteoporosis does cause this over time because if every time you move, you break a bone, you're going to stop moving, right? It's going to start hurting. And then also with the weak bones, you start getting less stability. You're more prone to falling and things like that. So again, connecting osteoporosis with menopause. So estrogen inhibits osteoclast resorption or osteoclast breaking down bones. When you're producing estrogen, you're inhibiting those osteoclasts. When you stop producing the estrogen is when these osteoclasts don't have the inhibition anymore, or they're not being inhibited, and they're just going to start breaking down bone like crazy. So as you hit menopause and suddenly stop producing the estrogen, the osteoclasts are suddenly like, hey, there's something stopping us, let's break down bone. So other things that can lead to osteoporosis besides postmenopause are smoking, diabetes, and a poor diet in calcium and vitamin D specifically. If you don't have enough calcium and vitamin D to make your bones strong and solid, they're never going to be strong and solid, and you're going to be way higher risk for osteoporosis anyways. There are also some medications that can put you at risk for osteoporosis. There is a form of osteoporosis, basically like a juvenile osteoporosis, that is seen in young female athletes with low body fat. So when you are really, really small or really, really heavy, your body thinks that you are not healthy enough to sustain a pregnancy, so you will stop ovulating in order to prevent pregnancy. When you stop ovulating, you start decreasing your estrogen secretion, and you're not releasing as much as you were. So the osteoclasts are no longer inhibited, and they can start breaking down bone. So female athletes that are in sports that are worried about size, like figure skating or gymnasts or cheerleaders, they usually end up with low body fat, and it stops ovulation entirely, and it stops the estrogen secretion, which leads to the osteoclast breaking down the bones, and it can lead to basically juvenile osteoporosis and a lot of stress fractures. So gymnasts, they're frequently breaking something, and they're not even really getting hurt. Like, they're not falling hard, and they might break their leg or something. It's probably a form of osteoporosis just because they're not ovulating or releasing the estrogen because they have such a low body fat. So how can we treat osteoporosis? Well, we can give estrogen replacement therapy, or give estrogen, and it would slow down the resorption because it would inhibit the osteoclast. But this is hormones, and it puts you at risk for things like breast cancer and heart disease. We have drugs called Fosamax and Actonel. These destroy osteoclasts. So instead of inhibiting them, they just get rid of them. Parathyroid hormone slows bone loss if given as a daily injection. So parathyroid hormone helps regulate calcium levels. So if you have parathyroid hormone, it is increasing your osteoblast activity and not the osteoclast activity. So if we slow bone loss by giving parathyroid hormone, we're increasing bones to be built instead of broken down. There's a Forteo, which is a parathyroid hormone derivative, which they use. It's basically made from parathyroid hormone, but you can only use it for about 2 years because it can cause bone cancer. So it's like we can fix you and give you 10% more bone density. However, only 2 years is all you can get because you might get bone cancer instead. Which, if you have to take one of the two, I'd rather have osteoporosis any day. So the best treatment for osteoporosis is actually to prevent it. So exercise, eat a good diet with calcium and vitamin D, eat good proteins, and take care of your bones. Making sure that you, especially in your young years, especially when you're growing, and in the early years where your bones are reabsorbing at a healthy rate, make sure that you're treating them well, getting the calcium and the vitamin D in there, so that way they can repair themselves when needed, and that way they're not pulling the calcium and minerals out of the bones to supply your body with them. Because the more you pull out of your bones, the weaker they are going to get. And if you're pulling out of them in your 20s, when you have estrogen and you're not postmenopausal, you're really going to pull out of them in your 60s and 70s when you don't have that estrogen. So let them build up thick and strong, so that way when you do get the estrogen depletion after menopause, they have a good surface and they're not pulling from weak bones already.